that the role of the CIO has changed totally. You know, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. I was the CIO for a 23,000 person health system, and one of the biggest challenges was to remain current on the technology and the trends that were going on myself.
Think of artificial intelligence as a orchestra. Right now, machine learning, deep learning is getting a lot of attention, so I sort of equate that to the string section. And obviously there are many sections to the orchestra, so someday soon, hospitals, healthcare organizations are going to be able to have amazing music.
We are seeing instances of folks popping up, us included, where we're having a primary care physician set up with the dentist in the same office.
I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record.
When we worked at Microsoft, oftentimes, you'd have crazy deadlines. People would say, look, we're not saving anyone's life here. We can't say that anymore. And we love that. It's like we can save someone's life. We can prevent a complication or a readmission by catching it.
A lot of the feedback people are hearing about former Vice President's remarks is that he was remarkably pragmatic. And then the one that I'm most excited about, he notes that the Medicare Innovation Center, which was created by the Affordable Care Act, has the legal authority to experiment with new models to engage patients for purposes of getting better value care.
Hyper-consumerism driving everything to a digital experience, because if we don't make it easy for patients like ourselves to use healthcare on our smart devices, companies like Apple are starting to do it for us.
I think we're right on the cusp of a huge digital transformation. It'll be interesting to see how CIOs sort of address that. Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 48. Today we look at the changing care settings and health innovation busts. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. Work with a trusted partner that's been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. Today's guest is a new friend and industry veteran. Rich Pollack is an advisor with Starbridge Advisors. Rich has more than 40 years, wow, of healthcare management experience, 20 of which were focused on the EMR success. Rich serves as the Vice President and CIO for VCU Health System in Richmond, Virginia, from 2005 until recently. Prior to that, he served 2 years as interim CIO for Clarion Health Partners, a $2 billion health system in Indianapolis, Indiana. Good morning, Rich. Welcome to the show.
Good morning. Glad to be here, Bill.
Wow, 40 years of healthcare management experience. I seem to be having these people on the show that have just a wealth of experience. What do you attribute your longevity in the space to?
Well, perseverance, I guess. But I actually had two careers. My first career in healthcare was in the field of radiology, and I thought I would stay in that forever. And I had about a 13-year career in that, and I transitioned in the late 80s into IT by happenstance. I happened to hit it at the right time. It was beginning to take off, especially on the clinical side, and I worked for a couple of vendors, and then for a large community hospital, and then sort of gravitated for some, due to some personality and hereditary defect toward academic medicine. So I've done 3 of those. The last one at VCU for about 12 years. But I'm passionate about what I do. I love the industry. I can't believe the time that's gone by, and it doesn't feel like 40 years to me. except when I look in the mirror, maybe. But I see the lines. But it's been just a great run, and continues to be a great run. Because I just have witnessed so much positive change over that period of time.
Yeah, so now you're with my friends at Starbridge Advisors. Give us an idea of what you're doing with Starbridge Advisors.
Sure. So I joined them shortly after I retired from VCU, and I knew David Muntz for many years. I knew Sue a little bit less, but still knew her. Didn't know Russ until I joined them. Recently completed a 6-month senior executive IT advisory engagement at a mid-sized health system up in Maine, and other than the traveling back and forth from the middle of January, which was a little challenging for me. I mean, Maine's lovely. I've been there many times in the summer and the fall, but it was great. It was very gratifying. They were a big Cerner client. They were rolling out Cerner in the ambulatory space. They certainly needed some help with new governance and road mapping and a whole bunch of other areas. A whole new executive team had come into place. So I essentially was a consigliere to the CIO, who was a very, very competent individual, but needed some extra help. So that was about a 6-month gig up there, and then after I finished that, I decided for some odd reason to go ahead and get my right knee replaced. So I've been spending the summer recovering partial right knee replacement, but it's doing extremely well. So I'll be back. I'll probably be back on the road after the first of the year.
Yeah, so it's interim leadership. I'll tell you, the New England, my wife and I lived in New England for 1 year. We lived in New Hampshire. And, two stories from that. One is we got 136 inches of snow that winter. And that was enough to tell me that I was not cut out. I was not strong enough character to live in New Hampshire for the long term. That was something else. And then the second thing was after a while, I was driving around with a friend, and I'm like, man, it's just kind of lonely up here. And he said, Bill, look out the window of the car to your right. What do you see? I said, trees. He said, look out your window to your left. What do you see? I said, trees. He goes, Bill, people move to New Hampshire because they love trees more than they like people. He goes, if you like people more than you like trees, you might want to go somewhere else. So that was my wake up call. It might be time to get out of New Hampshire, and we did after 1 year. So. Well, let me kick us.
Yeah.
Oh yeah, it is so cold, and Maine is the same thing. It's just so cold up there. But yeah, great friendships, great people up there. So let me kick us to the show. So we have 2 good news stories, and well, actually, before we get to our news stories, let me just hit on. I was looking through the news, and we had so many to choose from. Some just came up on my feed this morning. So one is Apple in talks to give veterans access to their electronic medical records. That's a huge story. That's in the Wall Street Journal, I think, this morning. So that's interesting. Maybe we'll talk about that in the future. Another one from Becker's, AI for precision medicine, top of mind in 5 years. Health system execs. In fact, they listed top 10, and number 1 and number 4 are both AI. One is AI in imaging and diagnostics. The other is AI in precision medicine. And then, the one I think we've talked about a little bit on the show before, but there's a story that says hackers are not the main cause for health data breaches. I think we've known this, but they did the research. They went back and looked at all the breaches, and it turns out that most of the data breaches were due to mistakes or security lapses within the healthcare organization. So those are 3 stories we're not going to look at this week, but we might look at in future episodes. Just wanted to highlight those. So I'll kick us off with the first one. The first one, the 7 most valuable health tech startups that failed in 2018. So we're getting close to the end of the year. We'll do a lot of these retrospective kind of stories, or we'll see them, and and also we'll start to look at predictions for next year for whatever they're worth. But here are the top. I'll give you a couple of the top 7 most valuable health startups that failed. Obviously, number 1 is Theranos, blood testing technology company, Silicon Valley, $9 billion valuation. Completely gone. Number 8, medical simulation. Number 9, Revision Optics. Number 12, Candescent Health. 13, Payeon. Well, probably start with a different name would have been better. Number 15 was WinX, a sleep therapy system, and number 22 was Claritas Genomics. I'm not outside of maybe one or two of these. I'm not overly familiar with too many of them. Are you familiar with some of these?
Well, yeah, so with a few, not all of them certainly. The Theranos is kind of interesting. Before I was at IU, I was at MD Anderson in Houston. So I was in Houston for about 7 years, and I was there during the Enron. This Theranos situation kind of reminds me of Enron, sort of a house of cards and phantom value built upon falsehood, fraudulent claims, insufficient vetting and validation up front. But lots of folks taken in with the promise of something that's literally too good to be true. So it's an analogous to me in my mind with Enron. Let's create something when there isn't anything there.
Well, that's a pretty big statement there, and I agree with you. The lure of the company was they were able to increase speed to get to the results, decrease cost, and maintain the same level of accuracy. So that was their claim to fame. And if they had been able to do that, that would have been a game changer. I think that's how it got the $9 billion valuation. But clearly,
no question about it. Yeah, it was based and built upon fallacious information, and so which took a while to come out. What speaks to our I guess our culture of if it sounds too good to be true, we want to believe it. So as opposed to questioning it.
Well, let's talk about that. So it did take a while for that to come out, and a lot of health systems are talking about innovation, and there's a lot of innovation models within healthcare. There's VC models, private equity. Some health systems are incubating companies. Some are acting as wet labs for startups, and obviously others are partnerships. So let's talk through these. What are some of the things we can do to vet these companies or these technologies to make sure that we don't end up in a partnership with the group that ends up on this list in 2019 or 2020? How do we make sure that?
Yeah, well, I think you need to have some sort of independent vetting and validation. Cross-reference labs. Is there peer-reviewed research that's been validated? Not just 100% relying on what the company is telling you, but can you go? Are there ways for you to go to validate that, whether it's from an outside source or even a competitor, or from your own academic capabilities if you're a university or a research institution and have the wherewithal to do that. So there's got to be some sort of vetting and validation that is beyond just what the company does.
Yeah, absolutely. I was as a CIO, I was asked to be a part of a team that was going to look at Theranos for our health system and how we might partner with them and whatnot. And the hardest thing for us was they were not overly forthcoming with information. Not only was potentially the information that they were putting out there not valid, but they weren't overly forthcoming.
Right.
And luckily for us, we were a little bit of a late adopter. So at that point, some of the things had started to unravel a little bit. So we didn't get caught up in it. But that is the risk. The risk is not being early enough to market and not taking the risk. Obviously, on the hindsight, you look smart because you didn't jump into something like that. But one of these could be a disruptor. And so, when I think about vetting these companies, I'm going to throw out some different things we looked at when we were vetting companies, and I'd love to get your thoughts on it. So the first one for us was always the leadership. When we met with the leadership, how did they operate the company? What was their vision? How were they thinking about the market? Did they come across as somebody that was in it for the glory, or did they come across as somebody that was, because somebody who's in it for the glory is in it for the money, and if they're in it for the money, that's a tough foundation. But if they're in it to really change healthcare, and you pick that up, and generally when a leader tells a story that that resonates, and you start to interview some of the people in the company, and their stories resonate. That's so the first thing we look at is leadership. I mean, what do you look for in the leadership of a startup? Let's assume there's a new startup coming to you at VCU. When you're talking to leadership, what kind of qualities are you looking for?
Well, I think you're looking for, I would be looking for a couple things. One, I would be looking for that, like you indicate, passion to change the game, change the industry, change, the delivery of healthcare in a very positive way. So the passion's got to be there. But there also has got to be a tremendous intellectual prowess there. So if they really are, doing something unique, then whether it's the person that's the founder or his co-partner or somebody in that organization that's got some significant intellectual prowess that has really broken through in a new way, and can articulate that and can explain it without giving away the company's trade secrets, but really be able to, lay out on a whiteboard, say architecturally, this is what is so different, and this is how how we came up with it. So that may be, both of those things may be contained within the same individual, or they may be, as I've seen often, two partners, or the CEO has their chief science officer, what have you. And then, we in an academic institution will have equal intellectual capability there to question and try to punch holes in that and see, in fact, what's real, what's not. And we certainly have done work with startups, with new companies that or like I characterize it, three guys in a garage type of thing. So, and that has its own challenges. But if we see that there's some value there, we kind of, go along and baby it along and hope to see it through to maturity.
Yeah. Well, so some of the other things, I'm sorry I have my arms folded here. My family's, I actually traveled for Thanksgiving. I'm in a very cold climate, and they kicked me out onto the porch so I wouldn't be too loud. So I'm freezing. It's just
sorry about that.
Transparency.
Yeah, I think one of the other startups that on your list is medical simulation, and now that may be overhyped and maybe at the Gartner peak, but nonetheless, we use it extensively at VCU. We have a series of simulation labs in the medical school, in the School of Medicine, that's been there since I think 1838 or some crazy time there. But that's been very successful for VCU in training and developing multidisciplinary teams to work together. That is has been very, very effective tool. So while it may have been overhyped, I wouldn't say that. And where it's on the peak at the Gartner hype cycle. But nonetheless, I think that's got promise if you put in the resources and the commitment to do it. We certainly had. Where Vision Optics, I have no idea what I do. I'm familiar with that.
Yeah, so when you think about medical simulation, I agree with you. It's on the top of the hype cycle, but it sort of goes into the next couple of things that I would vet. I mean, one is the need for the product or position in the market. Are there alternatives? And the challenge with medical simulation right now is there are a bunch of emerging new technologies that could displace, whatever's there now. So that's going to be a space that's in flux, I think, over the next couple of years, just because of the pace that AR and VR
right
coming along. So
I think that's a good point, Bill, because we were not using VR in our simulation labs. We were using a very multi-feedback dummies, if you want to call simulate patients, and assorted equipment around that in those labs to for those teams to work together in clinical situations, simulated clinical situations. But I do think the advent of virtual reality headsets are going to change the game up at some point in time. There's no substitute for that, human interaction, because that's what really happens in team-based healthcare delivery. So it'll be interesting to see how that factors in what we do currently with simulation.
Yeah, at the Exponential Medicine Conference, I saw a couple videos of augmented reality where, a physician, a surgeon with goggles on, actually overlays a whole bunch of data right on the patient itself and themselves. I can only imagine where that's going to go. Obviously, some of the other things we look for, financial models, technology fit, and those kind of things. But, I love that discussion. I think, we'll have to keep an eye on that, the changing landscape. But let's kick it to the next story. This is your story, so I'll let you set it up.
Sure, yeah. I took a look at this one in the news, that consumers seeking care in new settings for lower costs. So, because this has gotten a lot of play in the last couple of years of retail clinics, particularly VCU. We partnered with Kroger department stores and have retail clinics out there, and other folks are doing the same. So I look at it as retail clinics versus traditional urgent care versus virtual care models. So as I see those three sort of somewhat competing. Virtual care has actually out there, out California with Kaiser, a huge percentage of their outpatient visits are now virtual visits. Similarly, in Pennsylvania, UPMC has deployed a tremendous program for virtual visits across the state, and others are doing likewise. But you have to keep in mind that right now most of these are focused on low complexity, convenient to consumer care. So by that I mean it's the sore throat, it's the rash, it's the earache, it's the sprain, it's the stomach virus, it's that kind of thing. Although and the need for that, no question, and there's an advantage in not cost advantage, I think, in not burdening our multi-million-dollar facilities with waiting lists of people coming in to see a primary care provider in a clinic setting for a sore throat that could be done either in a retail clinic or virtually. So there is advantages to that, but there is a complexity curve here. And although the urgent care model, because they typically incorporate labs and x-ray capability that the retail models don't have, they can move up the complexity curve a little bit further. However, what strikes me that people are forgetting or not paying attention to in this is, remember that 5% of our patients consume almost 50% of our costs. So if you're going to really affect the cost curve, you really have to deal with the chronic disease, complex care populations with multiple comorbidities. These are fragile diabetics, asthmatic kids, et cetera. And they typically require a multidisciplinary team, mental health, social work, pharmacists, physicians, nurses, et cetera approach. Virtual visits, combined with home monitoring, may play a key role in intraclinic management of these patients with better outcomes and lower costs. But I just don't see the Minute Clinic or urgent care being positioned to deal with this. And that's where we kind of, we were at VCU, we put a lot of effort into setting up a complex care clinic to deal with that small population that incurs a huge financial burden.
I understand what you're saying, but I have a feeling the retail players are sitting back going, that's fine. You can have that business. The high risk, high complexity patients, you can have it. VCU we'll let you have it. Here's what we want. We do want the low risk, high volume business. We want to take the place of primary care. We would like, video visits are nice, but I think, the Walgreens, the Walmarts, the CVSs of the world would prefer the walk-in visits, because the walk-in visits mean that they're going to come in, they're going to pick up their medicine, and they're going to make money on their core business, and their core business obviously being, the retail items that they sell within the store.
Right.
I thought it was interesting that, the two examples you gave, UPMC and Kaiser, are both payer providers, right? So UPMC with Highmark and Kaiser obviously is an internal kind of model. And so, the televisits, yes, they're going through the roof, but they're the incentives align for them, right? So they're already getting paid on the insurance side. If they can do a lower cost model, which they are obviously with the televisits and the follow-up visits, they're actually going to do better financially. And so when the financial incentives align, I think you find that the behavior of the health systems line. Now, this year happens to be, I think, is going to be a banner year for most health systems. So there's no reason to shed any tears for them. But I think what we are going to see, though, is more and more pressure. You're going to see regulatory pressure changing the game. You're going to see retail players come in, and they're not going after the high risk, high complexity. They're going after the low risk, high margin business, and they're going to keep nibbling around the edges, as will outpatient surgery centers, which have for years, and outpatient imaging, which has taken revenue away from hospitals for years. And so that trend is going to continue of just, you're going to see more and more of that business go that way. How do you think?
I agree. I think that, I'm sorry, go ahead.
Well, as I was looking at this story, here's a couple of things from it. So it says, consumers' views on health can change rapidly. Attitudes towards such things as openness to seeking care in a retail clinic and to sharing health data with pharmaceutical companies have changed in just the last 5 years. The analysis of the HRI consumer survey reveals, the Institute wrote, many consumers are ready for healthcare to mirror other parts of their lives in terms of convenience, choice, and presence of affordable options with predictable pricing. The report added, companies that invest in deep data-driven understanding of their customers will be able to develop tailored products and services. So there's a lot of things, there's a lot of things competing for our mind share. When you're sitting in the CIO chair, when you're sitting in the executive chair, how are we going to prioritize? We're not prioritizing good and bad. We're prioritizing good and good. And so how are we going to elevate sort of the consumer mindset of how do we create more options, more cost-effective options for the patient consumers that we have out there, as opposed to maybe working on EHR optimization or RPA and other efficiency programs. Again, all good programs, but how do we elevate the consumer work that's going on?
Yeah, I think there absolutely has to be a focus today more than ever on consumer wants the consumer convenience, because they are voting with their feet and they are going to the retail clinic, they are going to urgent care, and even in our small marketplace, the virtual visits are taking off with a lot of our competitors. So we have, as I think a lot of other organizations, kind of no room at the end. Our 100 clinics and 800 providers or so were, it wasn't like they were waiting for patients. Waiting lists, even for primary care, was in the matter of weeks, and for the specialists in the matter of months. So if we can partner with a virtual care partner, if we can partner with retail clinics, as we've done with Kroger, then we have a channel. We open up new channels to have these patients, so retain them, integration into what they're going to come to us, hopefully when they want their knee replaced or something more significant. But we're able to retain that loyalty, retain the data in terms of a single electronic record, and still provide the kind of at-home convenience that people want. I mean, here's Black Friday, and it's going to be probably more people shopping online than actually going to stores. So that's just the reality of people want to do things. We do so much online at home, and being able to do virtual care, I think, is going to potentially overtake some of those retail clinics. The retail clinics are convenient. You're there shopping. You've got an issue. You roll right in. But it's typically I've got a problem, and it manifests itself in 11 o'clock on a Friday night or something. Yeah. I think virtual care has a significant role that yet to unravel and deploy at this point. And that's where I think health systems need to put a lot of focus on. And it's a disruptive force in terms of our clinician community. They have to think differently about how they organize their work and their day and their workflow to be available for that virtual, if you're going to use your own clinical staff for your virtual visits, as we've done. So it takes a little bit of work to work through that. Cool.
I'll let you have the last word on that, and we'll transition into the soundbite section. So during the soundbite section, yeah. I typically toss out questions in your direction, 1 to 3 minute answers. Not looking for elaborate answers. Sometimes people ask me, like, why don't you let them talk more about it? Well, this section is really to give the quick hit answer to some of these things. If you go longer than that, I'm not gonna cut you off. And if you want to throw questions back at me, feel free. I may have answers, I may not. We'll have to see. So let's start. Number one. So you've been the CIO for several organizations and have been interim CIO as well. What are you looking to do in the first 90 days of your tenure? And I realize those two are different. So let's say the first 90 days of your tenure as a new CIO, when you're first starting as a CIO versus an interim. What are you looking to do in those first 90 days?
Sure. Yeah. Well, good question. First, listen and learn. Make rounds with staff and caregivers. Begin to establish trust relationships with your new boss, with your peers, with your staff. I try to create an atmosphere of openness and being approachable. I think it's very important to do that right from the beginning. And finally, I would identify the most immediate and critical needs and address those via collaborative action plans with staff and with stakeholders. So there's always, something you don't want to be, step into a big pothole on your first 90 days. So you really do need to identify, are there some really critical issues out in front of you that require immediate attention? Often there are. Now, you set yourself up for the next 90 days by gaining an understanding of the organization's direction and goals and where IT is aligned or not aligned. So I think that's kind of what my thinking in those first 90 days is about. So it's about establishing trust relationships. It's about doing a lot of listening and learning, and making rounds and being very open and approachable. So you're just gonna be a sponge. You're gonna try to absorb a lot of information, a lot of history, a lot of culture that's been there for who knows how many decades.
Yeah, and I like your idea of identifying the urgent items. When I took over as CIO for a health system, within the first 30 days, we had a reportable breach. And, you think, well, I have some time to sort of get it up to speed, but you have to identify those emergency items right out of this. Yeah. So, all right. So the second question would be, we talked about full-time CIO. How does your approach to an interim CIO role, how is that distinct, and what are you looking to do there as opposed to a full-time CIO role? Yeah, it's much the same. However, I found that those roles provide me with a sense of objectivity and that's present when my concerns include my long-term success. So it's easier to confront and challenge established norms and culture as a, quote, independent source.
You're not, I could tell you that it gives you a different feeling, and especially if you're in a very challenging, and I've been in some of those very challenging environments where just the ability to, at the end of the week say, you know what, if they continue to just piss me off that much, I'm not coming back on Monday. It gives you a kind of a freedom in terms of being able to speak your mind and offer, very candid and perhaps not really looked for advice, but that needed to be heard. So there's an independence of thought that, maybe, should be there ideally in the permanent position, but frequently we couch that, we mellow it out a little bit because we're concerned about, the long-term ability to work and stay with this organization and be nice, with the folks over that long term. When you're in an interim, it's really much more cut and dry, and this is what you got to do, and tough up.
Yeah. Do you find, so a CEO might look at you and say, I guess there's two schools of thought. One would be, hey, just keep the seat warm. We're doing a search process. We're bringing somebody in. I don't find that to be the case so much anymore as the other, which is, hey, we're doing a search. We're bringing somebody in, but we'd like for you to really analyze this environment, give us that independent party, and if there's changes we need to make between now and the person starting, we're willing to make those changes. I find the CEOs to be more in that camp than the, just keep the seat warm.
Absolutely. My experience, that's been my experience as well. So it's been more of, we want you to keep the seat warm, but we also want to really, really take advantage of your experience and your capabilities to take a fresh look at everything we're doing here, and does it make sense or not? So yeah, I would wholeheartedly agree with that.
Absolutely. So, all right. So third question, EHR usability, one of our favorite topics. In fact, I think next week we're going to be talking to the people at class about their research on the subject. So EHR usability has been challenging for clinicians. What are some of the projects or tactics that you've used to make clinician experience with the EHR better?
Yeah, absolutely. I'm glad you asked that. We've had great success at VCU over the years. Recently scored a Davies Award, as you may know. And to a great extent, that is a result of us creating a very unique Office of Clinical Transformation that's wholly focused on improving the physician experience and his ability to deliver high quality care, the triple aim, high quality care. This was the brainchild of our first CMIO, Alistair Erskine, and published in JAMIA back in October 2011, if anybody wants to look it up. It was a considerable investment, well over $1 million a year, in informatics docs, informatics nurses, at the elbow trainers, et cetera. It was it took us about a year to make the case, myself and the CMIO together. And in the end, it was actually the dean of the medical school that coughed up the $3 million seed money for the first 3 years to get this off the ground. But it was hugely successful after that, and the organization began to. The board recognized its success, et cetera, and really was the secret sauce, as our current CMIO states. Real-world examples of that success were real-time dashboards that address the early warning in the ICU, patient safety, blood usage, and just a higher level of satisfaction among the medical staff. Not that everyone is in love with the EMR. I think EMRs, between the ideal user interface usability systems that are out there in the world and our EMRs, there's a big gap in the way they're designed. So there's no question about that. And they still need to, a lot of work needs to be done. But nonetheless, with that kind of focus on the clinician that Clinical Transformation Office provided us, and some significant skill sets within the EMR itself. So we were very adept, Cerner developers and users within our team that could really make the system and a lot of things with M pages and dashboard development and improve physician documentation. So there are absolutely incremental improvements that could be made all across the board if you've got a mechanism to link in your clinician community and as a collaborative force to do that.
Interesting. So Office of Clinical Transformation, if people are interested, they can reach out to you on that. That sounds like an interesting conversation.
Absolutely.
Fourth question. So ROI is such an important part of IT. When I sit down with operations people and finance people, they're always saying, how do you measure ROI, or how are you able to attain positive ROI on IT projects? What are some of your thoughts on measuring ROI within IT, and any tips on measuring it, reporting back on it?
Well, actually, not many. If you're talking about financial ROIs, much more so in terms of improved outcomes, patient safety, reduced sentinel events, reduced near misses, that we've been able to document. So that's a return on value, maybe not necessarily a traditional financial return on investment. And even those, you could not lay that 100% at the feet of the EMR, because the EMR is part of an ecosystem of changes that affected that. So other work processes that were put in place, individuals, training, a variety of things that affected those changes. But the EMR and our ability to build guardrails and tools absolutely affected those improvements in outcome. The one easy financial ROI I was ever able to nail down was our Patient Keeper project, which is a mobile system, still in use. We've had it for many, many years, that collects, it presents clinical data to the provider, but it also allows them to document their encounter with the patient and with the appropriate coding for billing purposes. And they replaced many years ago the little 3x5 index cards that they had in their pocket, where they would write down a level 3 visit or what have you. And because that previous paper process was so fraught with loss and people unable to interpret physicians, what they were documenting, et cetera, we literally documented millions of dollars in ROI return. So people initially didn't believe it until we ran a pilot with it, and then their mouths were agape. They didn't realize how much money was being left on the table in provider encounters. Remember, as an academic medical center, our physicians are salaried, so it's not like it's necessarily in their self-interest to be diligent about this stuff. So that was the one positive financial ROI that I could put down in a book somewhere and say, yeah, absolutely, take this to the bank. But I can't remember too many other than those.
I'll tell you, we'll keep moving on. The last question I have for you is let's talk about contractors and consultants. I get this question every now and then from CIOs and some others. Where have you found the best place to utilize consultants within health IT, and where would you avoid using them as a CIO?
Yeah, I found a couple of areas where where I have used consultants. One was to mentor and develop certain directors or managers that needed an intense focus more than I could provide, because they're moving into new roles. So in the case of our when we tapped a young individual to be our director of analytics in a newly developing analytics operation department, brought in a well-known analytits expert in healthcare to spend some time one-on-one with him, and it was hugely successful. Likewise, for a new associate CIO, I brought somebody. So I think in those, that's been helpful to me. The other is taking on new projects that exceed our internal bench strength. This is more contractors than consultants, if you want to the subtlety of the terms. So in other words, our CFO for many years at VCU was all about minimizing headcount. She didn't have any issue with spending a lot of money on contractors and bringing them in to address our projects, but she simply didn't want to add headcount. When she retired, a new CFO came in with a 180-degree different philosophy. We began to shed those contractors and build up the bench strength and the headcount within IT. So I think that was one area. It depends, again, what the philosophy is, but with all the projects typically coming in front of a CIO, it's a rare department that actually has the bench strength to man all of those projects, from the subject matter experts through project managers through report writers, what have you.
Yeah.
The other area is very specific skill sets that might be missing. So when we were in the throes of meaningful use, especially stages, we brought on project managers that had exceptional skills in understanding the regulatory climate and all of the rules and regulations associated with MU at that time. So that's one. Or we would bring on a remote HL7 programmer experience with a specific interface engine because we needed more capability, and they just were hard to find in the local area. So those are examples where contractors or consultants have been useful, in the past to me.
Yeah, absolutely. Well, that's all the questions I have for you. You have any for me, or we're good to go?
To you, Bill, about digitization in healthcare. It's getting a lot of play, and it's all over the map. It's everything from precision medicine through consumer devices at the home, what have you. Do you think it's being overhyped at this point?
No. I mean, and it's being hyped. It's really being hyped, and it's not being hyped enough. We talked earlier about how as soon as the financial models change, everything's going to change. People want convenience. They want online bill pay. They online scheduling. They want telehealth visits for my son's inside right now. He thinks he has tonsillitis. Well, it'd be nice to just get online with his provider and have a conversation, have them say, hey, whatever, because we're not even local to the market where he's at right now. So, I think that's going to change it. AR, VR, AI, machine learning. I mean, these things are, right around the edges and have the ability to really transform a market. So I don't think that's being overhyped. It has the potential. But what I think the thing that people underestimate is how long it's going to take, because of the fact that our incentives aren't aligned, the organizational change management that's required to move these multi-billion-dollar organizations. Even some small hospitals, people are surprised when I say, you realize that's a $2 billion company? And they go, you're kidding. It's like, no. I mean, even small hospitals are multi-billion-dollar, 20,000 employee organizations, and there's a lot of different entities out there that have agendas and have a voice in the community. So if that does slow it down, but it doesn't change the environment. The use of data, the use of just the emerging technologies is going to impact healthcare. I've found every one of my predictions to be about half as quick as it actually takes. So if I say I think it's going to transform healthcare in 3 years, it's usually 6. So
Right.
So hey, Rich, thanks. On Black Friday, thanks for coming on the show. I appreciate it.
Sure.
What's the best way for people to follow you?
Sure. I have. They can go to the Starbridge Advisors website. They'll see some blogs I have there. They'll see my contact information there as well, and can email me through that for any further follow-up or information. Happy to stay engaged. Just came back recently from Chime, and so lots of old friends in the industry.
Yeah. That's great. So you can follow me on Twitter at the Patient CIO. You can follow the show at This Week in HIT. Our website is thisweekinhealthit.com, and the shortcut to the YouTube channel is thisweekinhealthit.com/video. That's all for now. So please come back every Friday for more news, information, and commentary from industry influencers. Thank you very much.